Okay, I feel like it would not be a complete series if I did not have a video go out. So my battery died halfway through, which is annoying because I didn't notice it until I was done. So we're going to start over. So we were talking about some of the colostomies and the way to sometimes they can build a reservoir without having to do an actual out-pouch bag, which is nice for the patient. This is what a stoma looks like. This is a normal healthy stoma. This is what the colon looks like. And so when they're building a stoma, they just bring a piece of the intestine out, they suture it to the skin, and your job as a nurse is to make sure that this is healthy, moist, pink, that the skin around it looks really good. Some of you may end up becoming woundostomy nurses or enterostomal nurses, where this will be your job, where you'll go around and assessing stomas. Sometimes what the stoma nurses do is before the surgeon operates, they will identify where to place the stoma, and you'll have the patient stand up, and because you don't want the stoma like right at a waistline or where a belt's going to go. You're going to want to put it somewhere where you can hide it, so you'll have the patient stand up and kind of move, and then you would put like a mark there, and then the surgeon would go in and put the stoma in that spot for the patient. And then once the stoma is in place, the patient, and this becomes a nursing thing, you have to teach the patient how to do this. They put an adhesion on the skin, and on top of that adhesion is almost like a Tupperware lid. I don't know if you guys have seen these in clinical or not. And then on top of that, then the bag just sort of snaps onto that, and then the stool will drain in there. Now, depending on where the stoma is will depend on the consistency of the stool. If the stoma is higher in the small intestines, like an ileostomy or jejunostomy, the stool is going to be much more liquidy because there's still a lot of liquid content in it, and your patient is going to be more at risk for dehydration because they're not reabsorbing some of that water, so they're going to need to learn to drink more. But if it is as a colostomy, if it's in the ascending or transverse colostomy or something like that, it's going to look a little bit more like regular stool. And this would be a bag where the stool would come out. They can also do like urostomies, where it goes right into the bladder, and you can see this one is just draining down into a bag like a Foley, but it just drains right from the bladder. So they can do urostomies as well. So this becomes a big nursing thing. I'm sure you're going to see that in your practice. The next thing I want to talk about is colorectal cancer. Again, this is how it looks from a colostomy. No, not colostomy, colonoscopy. And you can see this big mass of malignancy here, a colon cancer. It comes in different stages, which is why we have all of our patients get screened with a colonoscopy, because you want to identify it early and then remove it as soon as possible. So if it's real early, like in a stage 0, sometimes they can remove it just during the colonoscopy, but sometimes they have to go in and do surgery. And then what they'll do is they can sometimes just take a section of colon out, and then they can reanastomose it, and they don't have to do the colostomy, and that's ideal. But if it's in several sections, or the area that they have to take out is too big, then they'll cut it off, and then they'll just do a colostomy. So surgery is the treatment of choice for these patients if it has gotten into the lymph nodes. And again, the surgeon will go in, they will take the cancer out, they will also take pieces of the lymph nodes, they will send it to the lab and identify if the malignancy has gotten into the lymph system. If it has, then the patient is looking at chemotherapy. If it has just gotten through here, they might look at surgery plus radiation. And again, it's going to depend on where along that colon radiation is taking place, because if it's lower in the rectum or anus, then you might have some perianal excoriation, things like that you're looking at. So colorectal cancer loves to metastasize to the liver, so hopefully you can get it before it metastasizes to the liver. But if they get it early enough, it's usually got a pretty good prognosis, especially if the patient is later in life. If the patient is 65 or older, it's usually less aggressive. If the patient develops colon cancer, you know, like around the age 40, 45, it tends to be a little bit more aggressive and it's harder to treat. The problem with any kind of surgery in the GI tract is bowel adhesions. The bowel does not like to be manipulated. It does not like to have surgery. And when it does have surgeries, it can develop these adhesions, these tight bands that start forming. Well, the problem when these bands form in the gut is that it starts compressing down in the GI tract. So now all the stuff that's trying to flow through the GI tract, and you remember the peristalsis keeps moving us, well, all of a sudden it hits something where these bands are and it stops the stool from moving through, and it causes an ileus, causes constipation, bloating, cramping, pain. So what we do in a patient who's developed adhesions, you get a good history, find out that they've had you know, cancer, manipulation to the bowel, and then you rest the bowel. Make them NPO to try to get the peristalsis to slow down. Usually you'll put an NG tube into suction so you can pull some of that fluid back up, you know, the other way out of the GI tract, and then hopefully you'll calm down. Every now and then you've got to go back in and cut those adhesions out, but now you're at risk for developing more adhesions because you've gone in and operated on the bowel again. So sometimes it's playing a little bit of, you know, catch up constantly. So you watch this for your patients who have had any kind of bowel problems or bowel treatment, as they can develop bowel adhesions and they're difficult to treat. Okay, so this is the end, and I put this little picture up because we've been talking about butts all day, so I thought I'd put up some cute little baby butts. So this is the end of this series, and then we'll talk more about some stuff in class. There's a couple other things I want you to know about, like appendicitis is very common, and I think I showed you what that appendix right here. Yeah, this is the appendix. Sometimes the appendix can get like some diarrhea, some stool in it, can get infected. Your patient will have some rebound tenderness here. They start getting fever, general malaise. They go to the hospital and get an ultrasound. Sure enough, it's infected, and treatment of choice is surgery. You just take them to surgery. You remove the appendix. It's called an appendectomy, and they're usually out of the hospital by the next day, and that's the end of that. So that's another common thing that you do need to know about when we're talking about GI stuff. And I think that's it. So study those things, and we'll go over some more stuff in class. If you have any other questions, give me a call.